My dear
Okay.
friends, yeah, my dear friends, the art of integration is being assessed very, very clearly by INICET, NEET PG, and in the prof exam as well nowadays. And here am I with the most beloved pathology educator of the country, Dr. Vandana Puri. I think when it comes to pathology, only we have one single stop solution to all pathology, concepts. Dr. Vandana, and it's my pleasure to be a colleague to her. And this is Rajiv Dhawan, your ENT educator with DocTutorials, and we are here for a very quick presentation. Will not take much of time because we do understand that the youngsters now need information in a proper way, but in a concise manner. So, Dr. Vandana, welcome to the session.
Yes, sir. So, so good morning, good evening, everyone. So, yes, thank you, sir, for your kind introduction. And I'm sure all our students. So we have got lot of students online. So I think the students will love this short case presentation.
Yeah. And one question which always comes in ENT out of rheumatology overlap question is, Wegener's and Dr. Vandana, can you show, yeah, please show a clinical vignette on that. Yes, please.
So let us start with the clinical case here, because this is one of the very important cases that come in the practice and exam. Okay. So try to answer the question also once you see that. Everybody should try to answer in the comment box. So this is a 42-year-old male who presents with chronic nasal congestion, recurrent epistaxis, and non-healing nasal ulcers for 3 months. He also complains of cough with hemoptysis. There is low-grade fever and weight loss. Examination shows a saddle nose deformity. Now, investigations show that hemoglobin is 9.8, ESR is quite elevated, the creatinine is 2.4, the urine analysis shows you RBC casts and proteinuria. So, chest X-ray shows you a lot of cavity nodules. Renal biopsy shows you very typical crescentic glomerulonephritis with pauci immune pattern on the immunofluorescence. So what do you think is the answer? So
Please comment in the
everyone,
chat box. Yeah.
so a lot of students are answering. Raghul is saying it is C and Ka. Uh, okay, but what is the answer? Everybody should
Diagnosis.
answer.
Yeah.
Yeah, diagnosis. Bhakti is also saying C and Ka.
They're
Harish is
predicting the
saying
next
C and
test.
everybody is saying C and Ka. But what do you think is the diagnosis, Bacho? That is correct only that you're saying C and Ka. But what is the diagnosis? So Danizi is saying GPA. So, sir, is he correct in saying GPA?
Uh, Guys, in ENT, when you have got epistaxis, cellular deformity, and with hemoptysis or plus minus renal involvement, the most common rheumatological disorder which comes to our mind is Wegener's granulomatosis, polyangiitis. The other things may be rarer possibilities, but we have to think about the commonest possibility. In the exam, always be like clinician and think about the most common diagnosis in the given profile, first of all. Okay. So nasal
So, as
congestion
sir
there.
said,
Yeah.
so as sir said perfectly, nasal congestion is there. There is hemoptysis and saddle nose deformity. So there is upper respiratory tract involvement, lower respiratory tract involvement, and kidney involvement. So as sir said, this triad should always make you think of Wegener. So Wegener's is W. W is like three. So it has three things together: upper respiratory tract, lower respiratory tract, and the kidney involvement.
This was the question of the NEET PG examination also. Again, you can see the two features given in the like sternal deformity and the septal perforation visible on Indian rhinoscopy, and they gave one biopsy picture finding also. So the beautiful integration question, and then they asked you about the most likely diagnosis. So again, like as Dr. Vandana told that whenever you got nasal feature with and necrotizing vasculitis picture over there, what is the diagnosis most likely? Wegener's granulomatosis. So this is sedulous deformity with septal perforation with vasculitis in the picture of pathology, which ma'am will guide you. And most likely it is Wegener granulomatosis. Not one now.
Absolutely correct. So remember this, as we have just now discussed, whenever you see a triad of upper respiratory tract, lower respiratory tract, and kidney involvement, always think of Wegener's. So these group of disorders fall under the category of ANCA-mediated vasculitic disorders. So which are ANCA-mediated vasculitis disorders? Apart from Wegener's, Wegener's is also called as granulomatous and cholangitis. Apart from that, we have two more disorders which are ANCA mediated. One is microscopic polyangiitis and the other is eosinophilic granulomatosis with polyangiitis. I hope everybody knows this is Chukstros syndrome. This is Chukstros syndrome, which you should be knowing that now it is called eosinophilic granulomatosis with polyangiitis. So remember, what is the common feature with all these ANCA-mediated vasculitis is that they have small vessel vasculitis. Now, that's a very important point. It has to be small vessel vasculitis. And then there are a lot of renal manifestations which are there along with it. So if you look at the, I told you upper respiratory tract, which sir also told you there's a saddle nose deformity. Lower respiratory tract usually presents with the cavitary lesions. Okay. And remember why cavity? Because they present with large granulomas. Okay, so they are large granulomas with geographical necrosis. That's a term that they give you. They can give you this also as a question with geographical necrosis. If they're asking you, that has to be Wegener's. So if you look at this, this all is your necrotic area with blue debris. Okay, so with blue necrotic debris. So it has a typical granuloma with large geographical necrosis. And you know, this is necrosis. So necrosis will slough off and it will come out as a cavity. So that is one point which everybody should be clear. Apart from that, lungs can show other manifestations also. So they can be multiple nodules. So patients can present with hemoptysis, alveolar hemorrhages, chronic dyspnea, pleuritis, interstitial lung diseases. All that can be seen in the lung. Now, these are the features which can be seen in radiology in the lung with interstitial lung diseases features or with presence of the cavities or with the pleuritis. So remember always, lung involvement has to be seen always. Okay. So whenever a person present with a cavity in the lung, think of secondary TB, think of Wegener's, or think of squamous cell carcinoma. These three differentials should be in your mind always. Okay. Now, when we talk about kidney, kidney has necrotizing glomerulonephritis. I hope everybody knows ANCA-mediated granulonephritis is also called as pauci-immune glomerulonephritis, and it is a type of RPGN. This is a type of RPGN. This is RPGN type 3. So these patients present with hematuria, proteinuria, they can have red cell cast, and it is typically pauci-immune glomerulonephritis, which I just told you. So if you look at the kidney picture, kidney is involved in 85% of the Wegener's. And if you look at them, they have necrotizing glomerulonephritis. So this is a crescent which is growing here. You can see that this is a crescent. Along with that, there is necrosis which can be seen in kidney. So this pink one is the necrosis along with the crescent which you can see here. That is very typical feature of the glomerulonephritis. Also remember, what are the other organ manifestations that you should remember? So apart from these three, always remember skin can also be involved. Patient can have purpura of the lower extremities followed by necrosis and ulceration. So whenever we look at the skin, there can be purpura, there can be livido reticularis, or there can be a lot of ulcers. So these are the skin manifestations which you should remember that can also happen. So they can be ulcers. Apart from that, in the neurological involvement, there the features can be there. It can be multiple mononeuropathy. So the patients can present as mononeuritis multiplex. So that point should be very, very clear. Now remember, when should you suspect GPA? Whenever we have discussed, and we are telling this again and again and again, whenever there's a triad of upper respiratory tract, lower respiratory tract, and kidney involvement. Now suppose kidney is not involved, only the respiratory tracts are involved, then this is called as limited Wegener's. What is this called as? Limited Wegener's. So limited Wegener's means when only the respiratory tract is involved and kidney is not involved. So look at that. So these patients might present with a very typical feature in the gum, and this is what is called as strawberry gums. So remember these gum here. So strawberry gum. I hope everybody remembers strawberry tongue is a feature of Kawasaki disease. Strawberry gum is a feature of Wegener's granulomatosis. So that has to be very, very clear here. Now, apart from that, remember always, we have, how do you diagnose it? We have to see the ANCA antibody. What is ANCA? Remember the term anti-neutrophilic cytoplasmic antibodies. Okay. So everybody can answer this, girls and boys. Everybody can answer this. So how many types of ANCA antibody do you know? We have two type of ANCA. Yes, very good. So we have P ANCA and we have C ANCA. P ANCA is called P ANCA because it is perinuclear. So this technique is called indirect immunofluorescence. Remember, it is an indirect immunofluorescence. Okay, because these antibodies are circulating in the blood. So you will have to add a substrate and then you will have to add FIT-C to see the fluorescence. So you do it in two steps. That is why it is indirect. Can you see here that only the nuclear lobes are shining here? So this is what is called P ANCA. Whereas when whole of the cytoplasm is shining, you can see the complete outline, complete cytoplasm is shining, then it is called C ANCA. Please remember, C ANCA has antibodies against proteinase 3, whereas P ANCA has antibodies against MPO. Remember, Prime Minister. Okay, so P ANCA always has an antibody against MPO, and C ANCA always has an antibody against proteinase 3. Remember, 3 is the third alphabet. That is why C ANCA is in proteinase 3. So, which is seen in Wegener's? In Wegener's, you have C ANCA positivity. But are all 100% cases positive? No. So you have positivity in 65 to 75% of the cases. Okay, so remember that. So ANCA negativity does not rule out Wegener's. Remember that. Okay. Now, the next question is for Sir. So what are the ENT manifestation of Wegener's? Because this is one of the very common manifestation of Wegener's.
Yeah. Thank you, Vandana, for a beautiful, overview of the pathology. And yes, ENT, ear, nose, throat. The most common part involved in vaginal is nose. So let's come to nose. Out of nose, one very famous question asked in the exam also is that what is the most common ENT manifestation of vaginals is sinusitis. Unresolving sinusitis to usual antibiotic courses. And if you do CT scan, you see exact evidence of sinusitis. So this is the most common ENT part of the vaginal story actually. So, but other features can be patient will be having crusting in the nose, and that crusting lead to mild epistaxis, not the frank one. And if you do the endoscopy of this patient, you will see septal perforation. And you know what is the support of the external nose over here is the septal cartilage. And septal perforation which occur in vaginals is in the both parts, cartilaginous part also, the bony part also. Septal perforation can be in the either the cartilaginous part or the bony part in different disorders, like for example, tuberculosis, lupus, leprosy. They destroy the cartilaginous part of the septum. And tertiary syphilis is the typical disease which damages the bony part of septum. However, Wegener's would damage both bony and cartilaginous part of the neural septum. So you'll see perforation in both part most likely. So this support will go away. If the support goes away, the nose gets depressed from there and goes saddle nose. So saddle nose deformity, septal perforation, and why crusting is occurring over there? Because when the perforation is there in the septum, the ear keep rotating right to left, left to right. And let me tell you one ENT secret of practice that the nasal airflow should be always medium airflow. Less flow causes blockage, more flow causes dryness. When the mucus get dried up due to overflow of the air in the nose, and that dried mucus is crust actually. So crusting in the nose. And when you try to remove the crust, there's a little bit of bleeding also, mild epistaxis also. And on the next slide, please. Now, yeah. So grossly, when you do endoscopy, you see a lot of crusting there. The tissue destruction is very evident, particularly in the septal bony cartilaginous part. Even turbinates can be a bit shrunken over there, like a trophic rhinitis kind of picture will be there. And if you do the CT scan, you'll be seeing the picture simulating sinusitis, which is the commonest ENT manifestation. Next slide, Bruno, please. Yeah. So this again, showing over there the saddle nose deformity picture and the nasal septal destruction completely with the perforation. Too much crusting over there is visible over there. So these are the nose part of the story. Now let's come to the ENT, ear part of the story. Now these patients, if you examine, a lot of time ear can be normal also, but what are the commonest thing to see? Number one is glue ear-like picture, serous pruritus media, because ET dysfunction is very common, finding in these cases. And otherwise, it can be frank otitis media also, the chronic otitis media also, which can lead to conductive hearing loss. So glue ear and the otitis media will lead to conductive hearing loss as an ear finding. So ear finding to be remembered are the glue ear picture or CSOM picture, which lead to conductive hearing loss. Now let's come to next one. Next one. Yeah. As Vandana beautifully showed, the strawberry gingiva and the oral ulcers actually. So these things are pretty common as ENT finding in these patients. And which remember the exam question also, strawberry gingiva is a feature of vaginal granulomatosis. Okay. And what about the now ENT, the T part, the laryngeal involvement? Very important question. It will lead to these subglottic stenosis because ultimately, chronic inflammation will lead to eventually fibrosis. And what is subglottic area? Cricoid is a ring-like cartilage, and the space in the cricoid is what? Is the subglottic area. The chronic inflammatory process will lead to fibrosis, and that's why there is subglottic stenosis. And this will lead to breathing discomfort and stridor. And there may be, the hoarseness of voice also along with that. So the laryngeal involvement to be remembered is the subglottic stenosis. Ear involvement is the glue ear and otitis media. But the nose involvement is the sinusitis. Number one, septal perforation, cerebral deformity, epistaxis. So I told you epistaxis with hemoptysis, with some nasal deformity destruction. As Vandana rightly said, think of Wegener as the first possibility. The next slide. The other features can be salivary gland involvement. It's like again, there can be xerostomia because of the decreased salivary production by the salivary gland. So these are the gross ENT manifestations of vaginal patient, Dr. Manna. Over to you.
Yeah. So, Bhakti is asking, ma'am, what are the other differential diagnoses which can be seen with this condition? So, always remember here, so whenever I'm talking about Wegener's granulomatosis, always remember this is a type of granulomatous vasculitis. Okay, so there is a granulomatous vasculitis which you see. Plus, there are a lot of necrotizing. I just now told you there is granulomas with large geographical necrosis. Okay, so that is one point which you have to be very clear. So whenever we talk about the differential, first thing you have to remember that it is a small vessel vasculitis. So we can have another vasculitis, one which is microscopic polyangiitis. But what is the catch point that you have to remember in microscopic polyangiitis? That microscopic polyangiitis is leukocytoclastic vasculitis. Okay, so leukocytoclastic vasculitis. So vasculitis alag-alag tarah ke hote hain. So this is leukocytoclastic vasculitis. Plus, they have typical feature of pulmonary capillaritis. Okay, so they present with pulmonary vessels which are involved, capillaries which are involved. And along with that, there is glomerulonephritis. So glomerulonephritis is both common in both of them. That is type 3 RPGN. That is pauci-immune glomerulonephritis. That is there. Third differential, which you should remember when there is a septal perforation, that is NK T cell lymphomas. Okay, so NK T cell lymphomas in hematology can present with septal perforation. And in this, you will see, so there are NK cells which are there. So this is a very, very aggressive lymphoma. So remember just a point here because this is an INICET question. This is also called as lethal midline granuloma.
This is very
Okay.
important question. Yeah.
So it is actually a misnomer. It is not a granuloma, it's a lymphoma. This is NK T cell lymphoma. So remember that point also here. So that is the differentials which you should remember on morphology, Bhakti. That is what you were asking if.
Vandana,
In
one
heart,
student asking good pasture syndrome versus this. Anything to be kept in mind? They are two
yeah.
different entities altogether.
So remember always good pasture syndrome. Number one, it is due to anti-GBM antibodies. Okay, anti-GBM antibodies, and it is typically type 1 RPGN. So you have to be very, very clear with this. It is a type 1 RPGN. Okay, and in this there is pulmonary plus renal involvement, pulmonary and renal involvement. So good pasture syndrome usually is not a vasculitis. Okay, so this is having a typical antibodies, anti-GBM antibody. Remember the RPGN. In Wegener's, we have type 3 RPGN, whereas in good pasture, we have type 1 RPGN. So that is one of the classical features which you have to be very, very importantly differentiating. Okay, also remember that if you do the immunofluorescence in this case, you will see linear immunofluorescence in the kidney. Linear immunofluorescence in the kidney. Whereas just now you have studied that in Wegener's, it is pauci-immune. So you have to do indirect immunofluorescence where you will find CANCA positivity. So these are very important clues which will help you answer a lot of questions. Okay, linear immunofluorescence, if it is seen, then it has to be good pasture syndrome. So plasmapheresis is curative because you just have to remove these antibodies. In Wegener's, it is pauci-immune. So you have to do indirect immunofluorescence. Here it is in kidney, when you're doing it, it is direct immunofluorescence. When you're doing it in the blood, it is indirect immunofluorescence. Remember that point always. Okay.
Yeah.
Okay. So once we are clear, can you answer this question now? Which of the following is most likely serological finding in this patient?
Please comment in the chat box.
Okay. So everybody clear? So rightly said, it is Cyanca. Pianca we have just now talked about. It is seen in microscopic polyangiitis. Anti-GBM antibodies, just now you have studied. Again, good pasture syndrome. Okay. And ANA antibodies are seen in SLE. Very good, everyone. Okay, perfect. Okay. So that is what you have to be very, very clear. Okay. So Bhakti is asking you a question. So if in exam they ask you saddle nose deformity, should they mark leprosy also, or should they not mark leprosy or syphilis?
It's very unlikely. If ENT is asking about the cellular deformity with septal perforation, with hemoptysis or any other systemic, manifestation like kidney involvement, proteinuria, hematuria, along with that given leprosy and tertiary syphilis are very distant possibilities. Always keep Wegener's first. Okay, Bhakti?
So I think that is the last question, sir. So this is the last question. So which is the feature which differentiates Wegener's from microscopic polyangiitis? We have just now studied. I hope you remember Wegener's and microscopic polyangiitis both are pauciimmune glomerulonephritis.
Yeah.
Both of them are small vessel vasculitis. Okay. Now what are the features which differentiate it? So number one, Wegener's will have granuloma formation. This is Wegener's. Okay. So this is feature of Wegener's. And P ANCA positivity is a feature of microscopic polyangiitis. Please remember in INICET, they are asking multiple choice questions nowadays. So be very clear with the options if you want to crack your INICET answers. Okay. So always when you're doing MCQs, do be sure to see all the options, not only the correct options, because multiple choices questions are the new trend in INICET exam. Yes. Okay. So definitely Wegener's, this is the first one. So granuloma formation is seen in Wegener's, whereas P ANCA positivity is seen in microscopic polyangiitis. So if it's multiple choice, you can give C and D. If they have to mark one, so you can say that because they have asked only Wegener's first, so I will go with C first. Okay. So that is how you will go with the answers, right? So remember that way. Okay. So remember, prepare for INICET, prepare for multiple choices. Okay.
Awesome. Really, I think a lot to learn from a small clinical vignette, and we went into the dissection of that into multiple directions. And I think there lies the way to crack a wonderful rank, and of course for the prof exam also, the Viva stories and all can be handled better if you get this kind of clarity about this thing. So the take home message from our side is that whenever you get the triad which Dr. Vandana highlighted, that there is you are upper respiratory involvement, lower respiratory involvement, and there is renal involvement also, think about the Wegener's first actually. So, okay, and go for the CNCA testing. Biopsy would be definitely very much, conclusive over there. Thank you very much, Dr. Vandana, for a wonderful, integrated session. And we will keep doing such sessions on this channel in the future as well with other specialities. Very wonderful educators will be coming together to give you more insight into these topics, because the whole idea of getting a wonderful rank in the NEET PG and INICET is about excellence only. The basic mediocrity like of information is not getting the good rank, that. So that's why let's target, premium information, high information, but in a concise way. Okay, thank you very much once again, Dr. Vandana. Thanks a lot.
Thank you so much, sir. And thank you so much, audience, for such a good audience who are answering continuously. So very, very good. So perfectly said. And a lot of questions again. So we have already told Yidnate that this is basically strawberry gingiva is more common. So he's asking whether you will get gingival hyperplasia also along with gingival strawberry or strawberry gingiva, or you can get gingival hyperplasia also.
Both are possibilities, yes, but like for the exam point of view, I would say keep in mind strawberry gingiva. But you are right, gingival hyperplasia is also a possibility in the oral cavity in these cases. Yeah, but
Okay,
strawberry
so
gingiva is
last
more
question.
common linked with, yes, yes.
Yes. So Mika is asking, Last question, what will be the better answer? C is always a better answer. I just told you, because 100% differential if you want to do. So Wegener's will have granuloma, microscopic polyangiitis does not have granuloma. So if you have to mark one option, go with C. So no confusion there. Okay. So any other question which is there? So if there are none, I hope, yes. So I hope this clears all the doubts, and I hope, thank you, sir, for teaching students so well. And I hope everybody is more learned now after this. So yes, all the very best, and everybody keep reading.
Thank you very much, guys. Thank you. Keep coming back to this channel for such more sessions with the different specialties as well. Thank you very much. Keep learning.
Thank you, everyone.